Hello, and welcome to Conversations from the World of Allergy, a podcast produced by the American Academy of Allergy, Asthma, and Immunology. I'm your host, Dave Stukas. I'm a board certified allergist and immunologist and serve as the social media medical editor for the Academy. Our podcast series will use different formats to interview thought leaders from the world of allergy and immunology. This podcast is not intended to provide any individual medical advice to our listeners. We do hope that our conversations provide evidence based information. Any questions pertaining to one's own health should always be discussed with their personal physician. The Find an Allergist search engine on the Academy website is a useful tool to locate a listing of board certified allergists in your area. Finally, use of this audio program is subject to the American Academy of Allergy, Asthma, and Immunology Terms of Use Agreement, which you can find at www.aaai.org. Today's edition of our Conversations from the World of Allergy podcast series is targeted towards both healthcare professionals and the general public. Today's guest is Dr. Dilawar Khokhar. Dr. Khokhar is a clinical assistant professor in the Department of Medicine and the Division of Allergy and Infectious Diseases at the University of Washington Medical Center in Seattle, Washington. At his institution, he established the Pediatric Allergy Clinic and serves as clinic director for the Adult Allergy Clinic. His clinical interests include drug and food allergy, as well as mast cell disorders. Dr. Khokhar, thank you so much for taking time to join us and welcome to the podcast.
Thanks for having me. It's a privilege to be on the podcast.
I think this is going to be a great conversation and filled with wonderful education for our listeners. But before we get into some of the details of today's topic, can you just begin by offering us some background as to why an allergist who lives and works in the state of Washington has a background in alpha gal syndrome, which predominantly affects people in the opposite corner of the United States?
Well, if you believe the New York Times, alpha gal can affect anyone, anywhere. But I grew up in Virginia. Virginia is where I call home, even though I'm out on the West Coast now. And there I had the privilege of being at the University of Virginia for 7 years for medical school and residency training. I started my career in allergy there, actually. I met my mentor, Dr. Larry Borish, and saw my first alpha gal patient with him. And then I got the opportunity to work with doctors Tom Flatz-Mills, Scott Cummins, Jeff Wilson, kind of all the juggernauts in the alpha gal world, if you will. And so that's kind of where my interest developed, and that's kind of followed me where I've gone in both fellowship and now out here on the West Coast. Patients see that on my CV, and they always ask about it.
Yeah, that's really cool. No, and you have a great background in this, and this is gonna be a great conversation. So let's start by just the basics. Can you describe the full name for alpha gal? Because I'm not going to say it over and over again, and tell us what it is.
Galactose 1,3 alpha galactose. Alpha gal is a lot easier to say. So it's an oligosaccharide that's found in mammalian tissue, but it's absent in humans, apes, and old world monkeys. And so it's something that we find in a variety of animal species, but not people like us.
Okay, and can you define oligosaccharide for the general public who may be listening?
Sure, it's a carbohydrate, and that's an important point. In the world of allergy, we often think about reactions to proteins because that's what antibodies like to bind. And so alpha gal is unique in that it's a carbohydrate epitope or a carbohydrate site that an antibody can bind to as opposed to a protein.
Okay, so right off the bat, we are learning that alpha gal is unique in many ways. Let's go back a little bit to the origin story. So you trained in sort of the hotbed, sort of the birthplace of alpha gal syndrome as we know it. And this is such a fascinating story. So I'm going to throw a bit of a curveball here, but I'll have you kind of walk us through it. What is cetuximab, and why is that relevant?
So cetuximab is a chimeric antibody against the EGFR receptor. It's used in the treatment of colorectal and head and neck cancers. And it's partially murine, partially human, so hence chimeric. And what was interesting about that antibody is that you had a lot of patients in the mid 2000s, so 2007, 2008, 2009, 2010, around that time period, that were having allergic reactions on first administration, which is quite strange. In allergy, we often think about first exposure being sensitization and then subsequent exposures causing the reaction. But you had people that were getting this on first exposure having reactions as severe as anaphylaxis. And so this prompted a lot of interest in why is this happening. And what they found is there were regional differences in this. And so it seemed that folks in the Southeast, Mid-Atlantic region, that they were having a higher percentage of reactions when you looked at the infusions and rate of reactions compared to what was seen in clinical trials. And then the rest is kind of history. Folks eventually found that alpha gal was present in the variable region of the heavy chain of this antibody. And it has to do with the mouse line that is used to produce this antibody. You have glycosylation of alpha gal in that region. and that's what the IgE in patients with alpha-gal syndrome can bind to, and hence cause an allergic reaction.
I love that story because it really it's unique, right? Like as you mentioned, people are having significant allergic reactions upon first exposure to this treatment, which is pretty rare in our specialty. And then that kind of led down towards trying to figure out what was going on. So if somebody isn't exposed to cetuximab, then how do they develop alpha-gal syndrome?
That's another unique aspect of the alpha-gal syndrome. Some people consider this an immunoparasitologic disease as opposed to a food allergy, and we can get more into that later. But essentially, parasite exposure, most commonly the Lone Star tick, Amyloma americanum, bites from that tick is what leads to sensitization to alpha-gal. But this can also occur with exposure to other parasites as well, potentially. But it's the tick bite that's thought to be the inciting sensitization event.
Okay, so somebody's bitten by the tick, and we're going to talk more about clinical manifestations and things like that. Are there other ticks that can cause the same alpha-gal syndrome, or is it really just specific to this one Lone Star tick?
So, that's an excellent question. And there is data to support that other ticks might participate in the sensitization to alpha gal. And this comes from a lot of excellent basic science work. They found alpha gal in tick salivary glands from different tick species in the gastrointestinal tract of different tick species. And of course, one of the other big things is we think of this as a American condition, you can say, given that so much of it has been discovered and described here in the US. It can happen in the United Kingdom, it can happen in Australia, other countries around the world that don't have the Lone Star tick. And so sensitization can occur through a variety of parasite exposures, with ticks having the best evidence. One article that was recently published was that there are some worms, actually, Ascaris lumbricoides, that contain alpha-gal as well. And so it's possible that other parasites beyond ticks might play a role. And my colleagues at University of Virginia have also proposed that maybe chigger bites contribute as well. So it could be more than just ticks, but definitely have good data to support now that ticks play a role in sensitization.
All right. Do we have any sense of how prevalent alpha-gal syndrome is today and whether it's increasing or decreasing or staying the same?
Yeah, so media always likes to popularize things, and so you would think this is skyrocketing. But there are some caveats there. I would say yes. It seems to be increasing, and we'll get into why. There are a number of factors there. Recently, the CDC published some data on the geographic distribution of alpha-gal based on laboratory testing.
Mm.
And you had hundreds of thousands of lab tests run, which is equivalent to hundreds of thousands of patients being tested, although you get multiple tests in the same patient sometimes. And what they found is 30% of tests were positive. Now, we don't know the clinical history of these patients, so you can't diagnose someone with an allergy just based on testing alone, right? Any allergist knows sensitization doesn't always equal clinical allergy. But it does seem to be increasing. And then my colleagues at University of North Carolina did an excellent case control study where they looked at patients with alpha-gal syndrome in an allergy clinic, and then they looked at folks in a general internal medicine clinic without alpha-gal, and in their controls, people that didn't have the clinical syndrome, there was about a 30% alpha-gal IgE detected. And so I would say that there is a pretty high rate of sensitization in tick endemic areas.
All right. So, and you teased out something really important, which we're going to dive into when we talk about diagnostic testing. But of those 30% that have an elevated IgE, or even with the case controls, what about just like in the general population? Do we know? Because you're not describing 30% of everybody living in certain parts of the United States, but do we actually have a sense of actual prevalence data?
No, this is an area that we need a lot more research and study on. I think that the best data is from people that suspected in endemic areas, right? But if you live in Seattle, what's the chance you're going to have alpha-gal syndrome? Probably way less than 30%, right? But people travel, they have different hobbies and activities, and we can get into some of the risk factors for what correlates with a higher likelihood of sensitization. But we need more data to determine the true prevalence.
Oh boy. So it's not like Vegas, right? What happens in Vegas stays in Vegas. Like you said, if you travel to certain areas, it can come home with you.
Mhm.
Oh boy. All right. Well, when alpha-gal was first discovered, it appeared really, and this is what I was taught, whatever, 10, 15 years ago. It mainly affected people in the mid-Atlantic and southern United States. Has this distribution changed in the past 15 years? And if so, how?
Definitely. And I think there are two factors to consider here. One is, factors that affect the tick species. the Lone Star tick, because we think that's the primary way in which people get sensitized, at least in this country. And then also kind of increased recognition and testing and people traveling.
Mm.
So what I would say is kind of tick-related factors and host-related factors. And so with global warming and deer migration, and deers are a vector for the tick species. They feed off the deer and often follow the deer. You see the increase in Lone Star tick in areas that previously wasn't present. In fact, in Michigan, where I did my fellowship, tick bites from the Lone Star tick are now the third most common reported tick bite. It was much lower previously, and now there are even some reports of the Lone Star tick going all the way into Canada. So they are moving north and they are moving more west, but the predominant areas are still the southeast, although more and more cases are being reported in the Midwest and more in the Northeast now as well too.
Wow. Have you diagnosed anybody in your area, like you yourself?
No, not yet. I've been at UW for a year and a half, and I'm still waiting for that first alpha-gal case here.
Okay. So really, this is like a deer story from what you're describing. It's fascinating, all the layers to this.
Absolutely, and I think there's some really interesting factors there. We think about why do these ticks, sensitize you to alpha gal, and one hypothesis is molecular mimicry. So
Mm.
these ticks want to survive more than just in humans, right? They feed off of other animals, and in animals that have alpha gal, by expressing alpha gal, you can trick their immune system into not responding and saying, "Oh, this is normal. We've seen alpha gal before." But when you get to humans, we don't normally express alpha gal, and the body all of a sudden is like, "What's this? This shouldn't be here." So I think there are a lot of parallels with understanding the tick's behavior in regard to the deer, and then how it impacts us as humans.
And then how climate and just the way our human beings interact with the world that we live in is impacting so many different levels of this. And this is kind of one of those, side products. It's fascinating. Well, I think this has been a great sort of background so far. So now I'd love to have you spend some time just describing how alpha-gal syndrome presents clinically. So how do we know that somebody has this? What are the symptoms that they experience?
So you often experience symptoms of IgE-mediated allergies, so things like itching, hives, difficulty breathing, wheezing, cough. So a lot of things you see with other allergies, but the kicker here is it's a delayed reaction after the consumption of mammalian meat. And so classically, it's between 2 to 6 hours after ingestion of, say, red meat, like beef, for example, or venison or lamb, and then you have onset of these symptoms. And many patients have cutaneous and respiratory symptoms and multi-organ involvement, hence the diagnosis of anaphylaxis. But a small subset of patients can have more nonspecific symptoms like gastrointestinal symptoms, which, as you know, can be sometimes hard to diagnose as an allergy because it's rare for an allergy just to present with gastrointestinal symptoms.
So it sounds like you can have this acute onset presentation, but it's delayed after eating mammalian meat. Can you have also have more of like a subtle chronic presentation? Is that what you're alluding to with the gastrointestinal symptoms?
Yeah, so there are studies that look at delay in diagnosis for alpha gal, and it can take up to 7 years to diagnose a patient after onset of symptoms. And so there are a small subset of folks out there, and I say small because the data we have so far suggests it's less than 1 to 2% of people that present with isolated gastrointestinal symptoms. They get diagnosed with things like irritable bowel syndrome, chronic abdominal pain, and it's not until somebody thinks, oh, is this related to red meat? This seems to occur more with ingestion of meat. They live in an endemic area where the tick's present. Let's check an IG to alpha gal that you might consider making this diagnosis.
Okay. Now, traditional food allergy reactions often occur within minutes of eating a food and rarely longer than 2 to 3 hours later. So, why does it take so long for reactions to alpha gal to manifest compared to the traditional food allergy reactions?
I think the gut is an amazing place. There's a lot of stuff going on there, and you have breakdown of proteins, you have accessing of different molecules, digestion and absorption takes time as well, and so alpha gal, as we talked about earlier, is a carbohydrate, right? But when you ingest meat, there's a lot of other things in there. It takes time for the body to break it down and digest it, and then we think the alpha gal that binds lipids and then crosses the intestinal barrier and then is exposed to the immune system deep within the body and then potentially systemically with basophils in the circulating blood, that is what leads to the allergic reaction. So it takes time to digest the meat and for the immune system to access it in a form which it can then recognize and have a immune response to. we see similar things in other types of food allergy as well. As you're probably familiar with, you've done work on delayed reactions to baked egg and baked milk. You have this concept of a food matrix, right? In
Mm.
that food allergy where there's wheat and other things around the egg or milk in the muffin, and it takes time to digest that and break that down and access the relevant portions that the immune system can react to.
Hmm. That's so interesting. We've also learned from traditional IgE mediated food allergy that severity of reaction can change based upon the amount that's ingested or other cofactors such as intense exercise during the time of ingestion, sleep deprivation, febrile illness, stressors, things like that. Do we have any idea if that applies to alpha gal as well, or is it too soon to know?
Absolutely. So some of this work is done out of Europe and other countries because they consume other animal intestines there more frequently than we do here in the United States. And what has been shown is pork kidney actually contains a very high concentration of alpha gal, and those reactions can be a more immediate, so less than 2 hours after ingestion, because you just have such a high burden of alpha gal. So the amount makes a difference there. And then there are case reports that have shown with cofactors that some of these reactions can occur before that 2 hour mark as well. So cofactors and the amount of alpha gal ingested definitely play a role.
And I'm sorry, did you say that other countries ingest more animal intestines than we do in the United States? Are
That's
those the
correct.
words you used? Oh.
Mhm.
All right. Have you ever had pork kidney yourself?
No, I'm actually a vegetarian, which is
Yep.
why I think it's also kind of funny that I've developed expertise in this area.
Well, you mentioned the delay in diagnosis, up to 7 years for most folks, and it's a unique presentation. What advice do you have for clinicians to help maintain a higher index of suspicion?
I think that there are a number of factors to consider here. One is, do you live in an area where the Lone Star tick is present? That's a big one, right? That should raise your suspicion. Taking a detailed dietary history and looking at, not just the meal immediately prior to the reaction, but during that day, a few hours earlier as well. And then asking specifically about mammalian meat products, beef, lamb, venison, pork, that sort of thing. Because chicken and fish, do not trigger this. They don't contain alpha gal. Although you have the potential for some, cross exposure, cross contamination, which we can get into later. But taking a detailed history, as you should with any condition, and then thinking about geographically where you are, where's the patient, taking a travel history, those would be the things I'd focus on. And then based on that, you could consider, taking the next step and doing testing, which is most commonly a blood test specific IgE to alpha gal.
Yeah, tell us more about that. So, what diagnostic tests should we be using to clarify the diagnosis who presents with the clinical history suggested for this condition? And then also, which ones should we not be using as well?
Absolutely. So traditionally, you and I know that we use skin prick testing to diagnose a lot of allergies, for better or for worse. And so, the traditional meat extracts that are used for skin prick testing, so like, beef, for example, pork, they have very poor sensitivity for alpha gal. So you're likely going to miss it if you just rely on skin test meat. But the blood test, the specific IgE to alpha gal, which is commercially available, is much more sensitive for detecting alpha gal. And this is another, I think, unique aspect of the alpha-gal story, in that when this was first described, and even today, we're still using the ratio of
Mm.
specific IgE to alpha-gal to total IgE. So those would be the two things that I'd always get. If you order a panel, they often come together. But if you're ordering individually, don't forget to order the total IgE. And the reason for that is we find if that ratio is greater than 2%, that there's a 95% probability that when you're exposed to an alpha-gal containing meat, that you'll have an allergic reaction. It's not 100%. Clinical history is still paramount, and food challenge remains the gold standard, as is the case for many other food allergies. But I would say total IgE and specific IgE are probably the two things to order, and definitely look at the ratio.
And that's a little different than the traditional food allergy, as with most things with this condition. So, what's important to know about the ratio of that? Are there a lot of like false positives with the alpha gal specific IgE, or can people have elevated total IgE for other reasons? Tell us a little bit more about that.
Absolutely. So elevated total IgE can occur in a variety of conditions. And the concern has always been if you have a very high total IgE, maybe you can get weak binding enough for a lab assay to give you a positive result that is not clinically significant. And so you want to use the ratio to as one of the variables to help you determine how likely do I think this patient has the allergy. And when you look at data from outside the United States and within the United States as well, combining the ratio gives you a little bit better confidence that this is significant. Our assays are getting more and more sensitive. They're detecting down to zero point 0.1 now.
Hmm.
And the research hasn't completely caught up. There are a lot of cases where that zero point 0.1 to 0.34 range, we don't know the significance of that. And so if you have low level positivity, you should interpret that with caution, rely on your clinical history. And I do think in those cases, getting a total IG is helpful because if your total IG is very low, then even a small amount of alpha gal IG detected could be significant.
Okay. We've learned a lot about aeroallergens having cross-sensitization with some of the food antigens that we test for. Obviously with birch tree pollen, there's a high degree of sensitization for those who have peanut allergy and vice versa. Have we found that with specific aeroallergens or other food allergens in regards to alpha-gal having, false positive binding and things like that?
Absolutely. Gelatin is a great example of this. If you have a positive alpha gal IgE, most of the patients will have a positive gelatin IgE, but many of them will tolerate gelatin containing products. This is something that is always a concern for alpha gal patients. As we focused a lot on, meat so far in our discussion, but there are other animal derived products like dairy, for example, and then also gelatin being used in medical grade products that, patients have concerns about having reactions to. And so you can get positivity with these other things when you test in alpha gal patients, assuming they have a positive IgE. But again, you got to go back to your clinical history. And this is where I think we've learned a lot from everything that's happened with the COVID vaccines and the concern about excipient allergies. I saw recently you posted on your social media page, a wonderful clinical commentary review on excipient allergy, really highlighting that many of these excipients contain such little protein, in the case of alpha gal, such little carbohydrate, that it's likely clinically insignificant, and that patients with these allergies can often tolerate these products.
No, it's an excellent point. Okay. Well, I think that was a great just walking us through the best way to sort of diagnose these patients and what tests to use and avoid and things like that. So here I have two important questions for you. Does everybody with alpha gal recall being bitten by a tick? And on the flip side, does everybody bitten by a Lone Star tick develop alpha gal?
Great question. There's still a lot here we don't know. But in general, patients that have clinical alpha gal syndrome do recall being bitten by a tick, and often more than once. They often recall the tick bite being very itchy. I'm again going to refer back to that case control study done out of the University of North Carolina. In that study, patients with clinical alpha gal syndrome recalled at least 4 tick bites, if not more. They recalled them likely because they were red and itchy. But you can't rely on the number of tick bites to distinguish between folks that are sensitized versus folks that have the clinical syndrome. Again, you have to go to the symptoms and the clinical history, because if you compare in the control group, patients that had positive IgE without the syndrome and folks that did not, those patients also recalled being bit by ticks more frequently. Other factors were living, near the woods, which kind of makes sense, right? Woods, deer, and the ticks on the deer. And then spending a lot of time outdoors. Again, you're increasing the likelihood you're going to get a bite the more time you spend outdoors. And so I would say that there is a correlation, but I can't give you a hard cutoff for it's these many bites to develop the syndrome versus, just sensitization versus, control group.
I mean, it sounds like, and correct me if I'm wrong, that a history of tick bite is almost irrelevant when trying to establish a diagnosis of alpha gal syndrome.
Yeah, so you definitely can diagnose patients that have been not bitten by a tick or don't recall being bitten by a tick. Patients just like us are not always the best historians, right?
Hmm.
And so you definitely can have the syndrome without recalling a bite. But I do think it's still important to ask because it gives you an idea about what is the patient doing? And did they have that local reaction? One proposal for the conversion between sensitization to clinical allergy is that the folks that have stronger local reactions to the tick bite, so more redness, itching, and swelling at the bite site, maybe the ones where you're getting conversion to IgE and then potentially have a higher likelihood of developing the syndrome.
Now, I know ticks can kind of migrate. Is it typically like, will the tick stay attached for a period of time while they're actually developing the redness and itching, or is it just so highly variable?
Yeah, so ticks often can become embedded into the skin, and I've had to in my internal medicine clinic as a resident actually had to remove ticks from patients. And so definitely they can stay there for a while. I think what's interesting here is that the redness and itching often leads you to identify the tick more quickly and get it off of you before it's become embedded.
Oh,
And so, given the fact that a lot of these patients recall redness and itching and removing the tick, I would say that even without becoming embedded, if it's bitten you and there's some saliva exposure, you've had the opportunity there to be exposed to alpha gal. And what is also interesting is this might be actually protective for infectious diseases. So they did a study with Lyme disease and looked at folks that recall having itchiness at their tick bite site and removing the tick. Those patients were less likely to contract Lyme disease, and so there might be a protective aspect to this as well.
oh boy, I think you just described the next TikTok phenomenon of people intentionally getting bitten by Lone Star ticks to prevent Lyme disease. Oh boy. Um, I never want to miss the opportunity to offer good education. So can you please clarify for everybody listening what is the proper way to remove a tick if you find one on your skin?
Well, I think that it depends on if the tick is embedded or not. Often you want to use a tweezer. A tweezer can be used to remove the tick. But if you have difficulty removing the tick yourself, this is a great opportunity to follow up with your primary care doctor. And so I would say that you want to do a thorough skin exam, so which can be sensitive, especially if you're examining a lot of different areas of the body. So often a friend or family member, or your physician, someone you trust, can do a full thorough skin exam to make sure it's not just one tick or multiple ticks. And then you want to use a tweezer to remove the tick and then dispose of it. Often, I mean, I use a little plastic container in clinic, but I mean, you can throw it in the trash, I guess. And so that's what I would suggest would be the simplest way to remove the tick.
And I did not hear you state to take a lit match and burn the tick off the skin.
That's correct. I would not recommend that. Higher likelihood of injury.
Okay. All right. Just wanted to clarify. Thank you. Well, I've received this question myself, and I would love to hear your answer to it. Shouldn't we just test everybody living in these endemic areas who has had a previous tick bite just to be sure, make sure they don't have, hidden alpha-gal syndrome?
That's a great question, and I would say that if anything, from this CDC data and the case control study that was done at UNC, we see that there are a lot of people that are living their lives normally with positive IgE to alpha gal. And I think there are negative consequences to making an incorrect diagnosis. And we see this in young children with food allergy, right? Unnecessary avoidance, increased anxiety, even carrying an EpiPen if you're not sure if you need it or worried about using it, that can negatively impact your quality of life. So even an EpiPen prescription in some cases is not benign. And so I think it creates a lot of unnecessary anxiety. I think that if you have symptoms and you live in an endemic area, you should see a board certified allergist and be properly evaluated. I think if you were to test everybody, you're going to create a population that is unnecessarily anxious and scared to go out and eat, to receive medical products. It can lead to delay in care. And so, because there are a lot of things like heart valves, for example, and other medical products that potentially contain alpha gal. And so I think it would have a lot of negative consequences.
Okay. No, I appreciate that. You're right. So these are not screening tests. I want to make sure we're very clear for everybody listening.
Absolutely.
Now, for those individuals who are unfortunate enough to be bitten by a Lone Star tick and they go on to develop IgE antibodies towards alpha gal and even the full-blown clinical syndrome, what's the typical time frame between the tick bite and then when they experience their first reaction after eating red meat?
That's a great question. Again, this is an area where we need more data. As I mentioned before, you have a 7-year delay in diagnosis after onset of symptoms. And so sometimes it can be hard to distinguish when they present to you so late, when was the sentinel tick bite and when was the exact onset of symptoms after that. There are some case reports that suggest it can be, weeks to months, but it can also sometimes be years. And again, we need more data in this area.
Okay. What's the best approach towards management of alpha gal syndrome?
Like any food allergy, avoidance is key. And the mainstay of avoidance is avoiding mammalian derived meats. So you don't need to avoid poultry or fish, for example. And then also carrying an epinephrine auto injector. Because there is a risk of anaphylaxis. Many of these patients have multi-organ involvement, like skin and gastrointestinal symptoms, when epinephrine should be administered. And so avoidance and prescription of an EpiPen are paramount.
Okay. This brings to mind a professional football player who I won't name, but famously, I think this was 6 or 7 years ago, had anaphylaxis on the way to a game and wasn't able to play that next day because they had shellfish allergy and they just couldn't help themselves. And they were quoted as saying, sometimes I just can't help myself because I love the taste and I just, I deal with it. I get an upset stomach and it's not going to progress or make my throat swell shut. Are there people with alpha gal that can have just a little bit of steak and, kind of deal with it? Or do we generally recommend don't go there?
Again, area where we need more research, but I think it's really important to recognize that food allergy is not a one size fits all approach anymore. And we can get into the concept of thresholds and reactivity and severity. But every patient is unique. Some patients are more sensitive, some are less. In the case of alpha gal, for example, you have some folks that are highly sensitive and will react to things like dairy, which do contain some alpha gal. And then you have some patients that are only slightly sensitive, and that if you really well cook a steak, they might be able to tolerate it. So that has been reported in the literature. The problem is you can't predict that other than off of clinical history based on any of the testing that we have. But I would say, like any shared decision, you should discuss this with your patient, discuss the potential risks, and if they are able to tolerate small amounts, you could consider continuing that. But they should always have their epinephrine auto-injector available. And so I think this is an area where there's a role for shared decision making. We used to think of food allergy as definitely an anaphylactic for all patients. And I think in some ways we do a disservice to our patients by thinking of it that way, because you generate a lot of fear and anxiety surrounding the diagnosis. I do think there is such a thing as mild food allergy. We just need to get better at diagnosing and managing that as a specialty, so we can better guide our patients and prevent unnecessary avoidance, fear, and anxiety.
Boy, and with your calming demeanor, I can only, I'm sure that your patients very much appreciate having that shared decision-making conversation with you. Now, we know that we can desensitize to other food allergens, such as peanuts, with oral immunotherapy. Is there a way to desensitize for alpha-gal as well?
So actually, there is a report in the literature that was just published. So desensitization to red meat in the setting of alpha-gal has been attempted, and there is a case series that suggests successful in some patients. As you're well aware, oral immunotherapy, food desensitization has risks,
Mm.
including risk of side effects, so allergic reaction, which can be as severe as anaphylaxis. We don't have an FDA-approved product like we do for peanut. Peanut has palforzia. We don't have that for other foods, including red meat. And the problem here is how do you control for dosing and how much alpha gal is represented in the meat? What protocol do you follow? And then you have to counsel on cofactors and other potential risks. So it can have a big impact on quality of life, but it has been attempted and it has been successful in a small group of patients. It's just an area we need more data and more study.
Is this something that people should start doing on their own?
Absolutely not. I would say that there are a lot of risks involved with this, and you want to make sure you're appropriately counseled, have all the information before you make a decision. Food oral immunotherapy is often time intensive. You're having visits with your doctor every 2 weeks. They're measuring your dose. They're having you follow a protocol. They're reassessing how you're doing and giving you guidance at every visit. So you definitely want to do this under the supervision of a board certified allergist.
Okay. What's the prognosis for somebody who develops alpha-gal syndrome? Can this resolve over time and go away? And if so, how do we determine when it's gone?
Great question. So this can go away over time, and it goes back to the ticks. So if you continue to get tick bites, your IgE will remain elevated or even increase further. But if you're able to avoid ticks, the IgE tends to decline over time. Every patient is different. Some people that have lower levels in the beginning might decline faster. Some people with very high levels may take longer. Generally, I would recommend checking an IgE once a year and following that trend. If it becomes negative and the patient is able to avoid tick bites, then I would consider discussing with them whether you should do a food challenge in clinic to determine if they're still sensitive or not. And even with a negative test, there still is a risk of having allergy. No test is 100% right, and so I think doing it in a safe setting with the appropriate emergency response team and resources available is very important. So you can lose this over time, and that's why there's value in rechecking the level.
That's interesting. I was kind of expecting you to mention something about like if you continue to eat red meat or experience reactions. Does that seem to prolong this? Do we know?
That's a great question. And, I am not 100% sure if we know the answer to that question or not. We definitely have data showing that with tick bites, the IgE goes up and avoidance of tick bites, it comes down. I suspect because most patients are counseled to avoid red meat strictly after getting this diagnosis, that there are very few that will go out and continue to challenge themselves and react.
Yeah. Okay. You mentioned a couple of times so far about other potential sources of alpha gal, and I use that word potential in italics for those who can't determine that's while listening. So you mentioned dairy. You mentioned some medications that contain gelatin. Walk us through, the story behind that. Does everybody with alpha gal stand the same risk of, experiencing reactions, or how should we counsel patients in regards to those types of exposures?
Yeah, that's an excellent question. So there are a lot of animal-derived products that are used in medications, and also in other things that are given to you in the hospital when you're admitted. For example, plasma expanders. So there's a product called gelafundin, which is more commonly used in Europe and is in the United States. This is used as a plasma expander, so infused through your veins, and it has a significant amount of alpha gal in it. And patients with the alpha-gal syndrome can definitely anaphylax on exposure to this product. And then you have things like stearic acid, which are animal derived, have the potential to contain alpha-gal and are found in a lot of the over-the-counter supplements, like magnesium supplementation, for example. And most patients tolerate these products just fine, although there are rare case reports of patients reacting. And so it goes back to how much of it is in the product and what's the route of exposure. Often small amounts and things that are taken orally tend to be tolerated by many patients, whereas things that are given intravenously or by injection, especially if they have a high concentration of alpha gal, like the gelafundin, for example, have a very high risk of causing a reaction.
Is this counseling that should take place at the time of diagnosis, or do we wait until somebody experiences a suspected reaction to a medication, or how should we, best approach this?
I think it is important to discuss with the patients at time of diagnosis because, as the internet is full of a lot of information, good and bad, and so patients will read a variety of things online. And this is something that I think is great to discuss with the patient at diagnosis, to go over what are the potential risks. You always want to make sure that if they have concerns, you're available to discuss with them and talk with them. This is one thing that I actually borrowed from your book, in that if they quote a reference about potential severe reactions or reacting to specific products, have them come in and bring the reference so you can review it with them and go through the strengths or weaknesses of that data.
No, I love it. Are you suggesting that not everything we read on the internet is true?
That is correct.
Oh, okay. We'll get back to that in a second. But before then, I heard you give an outstanding presentation on this topic at a regional allergy society meeting that we attended together just a few months ago. And you took the audience on this wild sidebar that seemingly didn't make any sense at the time. And you caught my attention. I said, where is he going with this? But wow, you brought it back around beautifully. So, if I may, I'd love for our listeners to go on that similar detour. And with that, what is CROFAB, and why is that relevant to a discussion about alpha-gal syndrome?
Yeah, thank you for bringing that up. So this is actually a case that I was part of at the University of Virginia as a resident. And so we had a patient that received Crofab. It's a snake antivenom. They had bitten by a snake and had envenomation of the bite. And when the patient was administered Crofab, they developed acute onset urticaria. And so you got to take a deep dive into, what is Crofab. So it is a antivenom that's produced by immunizing horses and sheep. And why is that important? Those are mammals that contain alpha gal. And so this antibody that is derived from these animals contains some alpha gal. And so you have the potential for allergic reaction to these antivenoms when administered to a patient that has the clinical alpha gal syndrome. And so this is another way in which alpha gal can sneak its way into medical products and cause potential issues.
No, I love that story. It's so unique and fascinating. It just dives again into the level upon level that we see with this. Okay, so what do you think is the biggest unanswered question surrounding alpha-gal syndrome at this time?
I think the biggest question is how do we individualize management for patients? And I think that's kind of a big question for food allergy in general. And I think the reason that's the biggest question is, for so long as we learn more about this syndrome, our guidance has always been, to avoid things that contain alpha gal. predominantly red meat, and if patients have reactions to dairy, also recommending dairy avoidance. And I think we need better ways to determine, who's at higher risk versus lower risk, and how we can individualize the management for what does the patient truly need to avoid versus not. And then, also discussing, other therapy options. I hope we get more data on the oral immunotherapy desensitization for alpha-gal, because I think that that is a great option to offer patients that want to do something more than just avoidance. Of course, like any therapy, there's risks there, and as your board-certified allergist, you should discuss that, with your patients. But I think how do we individualize management is the biggest question for me.
Okay. And what are some of the most common mistakes that you see regarding the diagnosis or management of alpha-gal syndrome, or both?
I think some of the biggest pitfalls that I see is just folks not being aware of it. I'm going to refer back again to those CDC reports, and the rest of the medical literature, looking at when you survey providers about their comfort or awareness of the syndrome is pretty low, especially outside of endemic areas. And it can be as low as 20, 30% of folks that feel comfortable diagnosing and treating this condition. And I think we either need to improve our referral process to allergists when there's a suspicion for the alpha-gal syndrome, or we need to empower folks outside of our specialty to consider this diagnosis in certain situations, because other physicians are capable of ordering a blood test at least if a clinical history fits, and that can be helpful, because the reality is there's no way that allergists can manage this on their own. There are too many patients that would be seeking evaluation, and as the prevalence of this potentially increases, you're going to have a larger population to take care of, especially if the ticks and deer keep moving everywhere. I think of this in the way that I think of penicillin allergy. How can we empower others to help us manage this condition better? And I think we're already seeing this in our gastrointestinal colleagues, the GI docs. They've started publishing guidelines on when they recommend testing for this and referring to an allergist. And I think just making people aware about how this can manifest in their patients, that there is testing that can be considered, and that they should consider referral to an allergist if they have a high suspicion for this, are all things that we can do better as a specialty.
Okay. Well, as you alluded to just a few moments ago, we live in a world of misinformation and Dr. Google. What are some of the biggest pieces of just plain bad information that you've encountered online surrounding alpha-gal, and can you set the record straight for us?
Absolutely. So I have seen a lot of misinformation about things you can react to. There are a lot of folks that they see a case report about a supplement or product that a patient reacted to. They go down the rabbit hole trying to figure out what's the ingredient, and then they're like, okay, I need to avoid everything that contains this. And so a lot of what I see with the alpha-gal syndrome is unnecessary avoidance. A good example of this is heparin, which is porcine derived. And, the majority of alpha-gal patients tolerate heparin just fine. But my colleagues at UVA will tell you that they get consulted about this all the time when a patient gets admitted to the hospital. They have a concern or even a diagnosis of alpha-gal syndrome about their ability to tolerate heparin. But we give heparin to patients that are hospitalized all the time. Even those with alpha-gal, and the vast majority of them tolerate it with no issue. So the biggest misinformation I see online is just the degree of avoidance that folks recommend based on their personal experience or what they read or their own fear and anxiety surrounding the topic.
Anecdotes are not evidence, correct?
Correct. Anecdotes are not evidence. 100% agree.
Dr. Coker, this has been so beneficial and helpful. You provided us a wealth of information. I think this was basically a mini primer on alpha-gal syndrome. Did we miss anything?
No, I think we covered a lot. It's been a privilege to be on the podcast and chat with you today. Let me know how I can help in the future.
Oh, thank you so much. We really appreciate you taking the time to be with us today. We hope you enjoyed listening to today's episode. Please visit www.aaai.org for show notes and any pertinent links from today's conversation. If you like the show, please take a moment to subscribe to our podcast through Apple Podcasts, Google Podcasts, or Spotify so you can receive new episodes in the future. Thank you again for listening.